In somebody that does have restricted breathing that we need to do an escharotomy on, the landmarks basically are the tops of the axilla on the outsides of the nipples, because it would hurt if you went inside or on top, and all the way down to the bottom of the rib cage, following under the rib cage up to the xiphoid. So you're making a W, just here and here. So basically just 4 cuts. You're going to do these in layers for the reasons that we talked about. Bleeding is the big issue. You don't want to go too deep. You don't want to get into nerves and things like that. I think that's pretty uncommon. I have 0 experience doing this, but from what I've read and sort of hive knowledge, that seems to be rare, pretty rare. So you're going to make, and the landmarks are a little bit difficult on here, but we'll overcome. So you're going to make just sort of increasing depth incisions. So I'm going to go through the epidermis here. Hopefully I didn't just slice his nipple. And so I've made just a little kind of a superficial cut. I don't have any splitting yet, and so I'm going to just deepen that up a little bit. And so as we've talked about a bunch before, the hardest part for you guys is just the hardest part for you guys is just handling the instrument. So again, you're holding the scalpel like a pen. That's kind of how you get the most function out of it. So I've got my one side there. I'm going to go ahead and go up my other side here. This may be enough. And again, I'm doing multiple layers. I think that's the key that I really want to emphasize, is that you're not just doing a hack job and going super deep. You're trying to slice down and slice down and slice down until you get into pink bleeding tissue, and more importantly, as the doc said, until the patient's able to ventilate again. And you're going to see a big split. The example that I use is, think of a burnt hot dog in the grill when it pops open. It's really similar to what this is going to look like. So I've got my lateral edges, and then I'm just going to trace the insides of the rib cage under the xiphoid in a W. So super easy, not much thought to this. Totally normal.
He's bleeding blue.
Yeah, good. Any questions on that?
So we are connecting these, right?
Yes.
Okay.
This is all contiguous. So think of it. This guy has a 1 foot long tourniquet all the way around his body that's compressing his chest. I need to release this plate of the tourniquet so that his chest can rise and fall. So these absolutely need to be connected. Next steps, if this didn't work, would be to go across the top, and then perhaps even a window under the nipples here, and then even considering going down here and here. Okay, but again, right now I'm just worried about the W. Probably we're never going to have to do this, crossing our fingers. But if you do it and need more ventilatory room, then you will have the option to do that. Okay, and then again, consider bleeding is going to be really significant. Opening up the bag of TXA or withdrawing some TXA from the bag, squirting it onto gauze, and putting that in a pressure fashion, packing it into the wound, not just kind of setting it on the wound, but actually filling the gap with it. Same with the 1 to 1,000 epi, 1,000 epi of gauze packed into the wound. Any other thoughts, Rob?
No, that's good. So